Hello everyone, we'll continue to summarize the high yield questions now for the cardiovascular system. Okay, so the first case scenario that could present, usually they bring 60-year-old, let's say for example 60-year-old man, came in just routine follow-up. Okay, so the most important thing you want to know what they came in, physical exam, test results. Okay, so this patient have echo, left ventricular dimension and systolic dimension of 42 mm, okay, and ejection fraction 60%, and the aortic valve have sclerotic changes, and there is severe aortic regurg. Now they're asking what's next step, like what is they're asking, do you do surgery? What do you do? Do you do surgery? Do you do routine follow-up? So you gotta know when do you intervene for aortic, when do you do surgery, when do you do follow-up. So that's why they ask this question, because they want you to know when do you do each one of them. So in this case scenario, you repeat echo in 6 to 12 months, and I'll tell you why. The reason we do that, so the only time we do surgical valve, aortic valve replacement, if there is associated symptoms. This guy came in with dyspnea. Okay, so now with this question they want you to know when do you do aortic regurg, when do you do aortic valve replacement. Okay, so you do replacement if there is associated symptoms, okay, or if there is the EF is less than 55%, okay, or if you have left ventricular and systolic dimension more than 50 mm. Okay, so in this patient they don't have that. So you see EF it's more than 50, dimension is less than 50, okay, no symptoms, so they don't have any indications for aortic valve replacement. Okay, so that's why we don't do aortic valve replacement. So that's a case scenario. It's very high yield. Okay, okay, another very high yield question that they can bring, 70-year-old male or woman came in for pre-op evaluation. Okay, pre-op evaluation, they tell you medical history, hypertension, diabetes, obstructive sleep apnea, peptic ulcer disease. Okay, and they did tell you, okay, they want a pre-op evaluation for knee replacement. Do you go ahead and do the knee replacement or not? So this one you want to know, okay, what's your best next step? Okay, so the best next step in this case, it depends. Like, so this is what you want to know. You want to know how to evaluate somebody pre-operatively. First you check is there is high risk cardiac conditions like unstable angina, decompensated heart failure. If there is any, you stabilize before surgery. If there is no high risk conditions, then you see is it low risk surgery or no. Okay, if it's low risk surgery, just go ahead. If there is if it's not low risk surgery, like orthopedic surgery is intermediate risk surgery, it's not low. So if there is intermediate, you check the revised cardiac index, which basically you look if there is any history of ischemic heart disease, any history of congestive heart failure, any history of stroke, TIA, diabetic who's taking insulin, pre-op creatinine more than 2. So if there is any of that, this is considered, if it's more than 1%, then you would check the metabolic equivalent, which mean are they able to walk, dress themselves, use toilet, do light housework, vacuuming, all of that. This mean climb flight of stairs, run short distance, you know. If they're able to do stuff, this is high metabolic equivalent. This mean that they can do the surgery. If there is low metabolic equivalent, then you do further cardiac testing like TTE, stress testing. So in a summary, you do other tests before you go ahead with the surgery only if there is somebody who has stroke, heart failure, are unable to walk, okay, or if an intermediate risk surgery, okay. If this, then you do like TTE, stress test, okay, all kind of things. Other than that, if somebody's able to walk, do stuff fine, and doesn't have like high risk conditions, like doesn't have arrhythmia, decompensated heart failure, severe valvular disease, aortic stenosis, mitral stenosis, decompensated heart failure, and they don't have like the risk factors like associated, like no heart failure, no insulin use, no creatinine elevation, no ischemic heart disease, and they're able to do stuff around, then you just go ahead, okay, we proceed with the surgery, okay. And you kind of clinical judgment, okay, you see how they're doing, okay. If their exam is not stable, you know, you don't do the surgery, okay. So that's kind of the case, okay. Let's move on to the next case scenario, okay. What is the next case scenario? Okay, the next case scenario, you see, okay, you see they bring you 54-year-old, came in with fatigue, man with fatigue, okay. With fatigue, they check, okay, why you check, you do labs, hemoglobin 9.2 and LDH, lactate dehydrogenase, is like 1600. What that tells you, whenever you see these combination, there's only one thing, like actually this is very common, like one of the options that could cause that. What is their diagnosis? And this diagnosis could be hemolytic anemia. This is another case scenario. They bring you to like, okay, elevated hemoglobin is low, LDH is high. What's the diagnosis? This one is hemolytic anemia. Okay, now they bring you another case, is very high yield. Then bring you like 50-year-old man, came in with chest discomfort, okay, chest pain, and then have paced rhythm. You do EKG, paced rhythm. So now you gotta know what kind of stress test you would do. In this patient who have a pacemaker, you want to do pharmacologic radionuclide imaging. That's what you want to do. So when do you do each stress test? Because they bring this discussion, this question, because they want you to know something, right? So you do exercise. So somebody who have pacemaker or left bundle branch block, or patient unable to reach the target heart rate, in this case you do pharmacologic stress test with adenosine or dipyridamole, okay. Basically you use this non-selective adenosine agonist that dilate the coronary arteries without increasing heart rate or blood pressure, okay. But this one you should avoid in asthma, in patient on dipyridamole or difeline, okay. This is the stress test. Exercise test, who do? You do somebody who can achieve target heart rate, okay, but not like you and me, but not for somebody who had pacemaker, left bundle branch block, or unable to reach heart rate. So it's like in this patient you do a stress test. You do the pharm stress test. Okay, now there's another one. So the pharmacologic stress test we can do in somebody with asthma, okay, or taking some medications, or unable to reach the heart rate. Which one? What do you do in this case then? You want to do stress test. You do the Bierman stress echocardiography, okay. But you don't do it if there's tachyarrhythmia. You try to avoid the Bierman stress echocardiography, okay. And the pretest probability, usually the one that are high, only men age more than 40, and women, typical angina in men more than 40, or typical angina in women more than 60, okay. So that's kind of the difference, the main thing. Okay, let's move on to the next case scenario, okay. Another case scenario, they bring you a patient, like 68-year-old, came in for lower extremity edema, right? They have edema and then JVD distension, okay. So edema, JVD distension, and what would you see on the echo? They will ask you, okay. They give you other COPD, bad COPD, okay. So somebody who had bad COPD developed edema and JVD distension. What's on their echo? You gotta know what's inside their echo without even doing the echo. This is magic. This is the power of medicine. This one you could see. This one you suspect there's heart issues and coming from COPD, right? So this is cor pulmonale. So cor pulmonale, lung put a pressure on the right ventricle and dilate. So in echo you see right ventricular dilation, okay. So that's kind of the idea here, cor pulmonale. causes right-sided heart failure due to a primary pulmonary disorder, absence of left heart disease, usually in COPD, cystic fibrosis, obstructive sleep apnea, pulmonary embolism. It causes dyspnea, fatigue, exertional angina, syncope, JVD, edema, palpable right ventricular heave, loud P2, tricuspid regurg murmur, hepatomegaly with pulsatile liver. On EKG, you could see right incomplete or complete right bundle branch block, right axis deviation, right ventricular hypertrophy, right atrial enlargement. Echo shows pulmonary hypertension, right ventricular dilation, tricuspid regurg. And on the catheterization is the gold standard for diagnosis, which is elevated filling pressure, decreased cardiac output, and pulmonary hypertension. You can see that could diagnose the cor pulmonale in this case. Okay. Now, another case scenario, let's throw in an easy one. You see 35-year-old came in with blood pressure 149/95, okay, in the office, but they tell you, oh, I just checked at the supermarket, it was completely fine. What's the issue? Okay, there's discrepancy, man. There's discrepancy. What is the best next step? You do 24-hour ambulatory blood pressure monitoring, okay? Because you don't know. So when else do you do this ambulatory blood pressure monitoring? When there's discrepancy between home and physician office of blood pressure reading, white coat hypertension, like in this case. If there is paroxysmal hypertension, pheochromocytoma, if there's autonomic dysfunction, if there is resistant hypertension, hypotensive symptoms on antihypertensive therapy, and the criteria for that: 24-hour average more than 125/75, and daytime more than 130/80, or nighttime more than 110/65. These patients you want to do 24-hour urinary 24-hour ambulatory blood pressure monitoring, okay? So now another case scenario, they bring you, okay, patient 32-year-old woman, pregnant, okay? You do on exam, you see open snap mid diastolic murmur with a pre-systolic accentuation, and they tell you what's the diagnosis, okay? Murmurs are high yield, so you do this is mitral stenosis, okay? Mid-diastolic opening snap, mid-diastolic murmur. It's like aortic regurg causes systolic, mid-systolic murmur. This one causes mid-diastolic murmur, okay? So here is the case scenario, okay? Now let's go another case. Okay, you see somebody, let's say 60-year-old, came in, leg pain with walking, okay, leg pain with walking, and then on exam you see they tell you small ulcer on the tip of right big toe. What? And they tell you, okay, what is that? I mean, that's obvious. This is peripheral arterial disease. This is easy. This is, you can tell, okay? And usually, so when is the diagnostic ABI? ABI, if it's 0.9 to 1.3, this is normal. If it's less than 0.9, this is mean peripheral arterial disease. More than 1.3, this is calcified or uncompressible. Sometimes they bring you another question. Okay, ABI is fine, but it's still high suspicion of PAD. What do? You do exercise ABI, okay? Okay, now they bring you another question. They bring you a 30-year-old lady, okay, woman with continuous murmur, okay? They bring you lady this continuous murmur. What does that mean, continuous murmur? And then what associated with? Okay. They bring you what is this continuous murmur associated with? So this one, continuous murmur. This means there's either patent ductus arteriosus or coarctation of aorta. Which one associated with coarctation of aorta? And the answer would be, let's say, short stature, okay? This means that it's likely they're referring you to Turner syndrome. So coarctation of aorta, what could cause? Cause headache. So this is like kind of discussion for coarctation of aorta because it causes continuous murmur because of the anomaly. It can block, so the patent ductus is going to have a blockage, right? So the patent ductus arteriosus can stay open. So clinical cues could cause headache, epistaxis, hypertension, difference in the blood pressure between upper and lower extremities, diminished or delayed femoral pulses because of the stenosis, well-developed upper body compared to lower body. So basically, coarctation of aorta is like a stenosis in the in the aorta, like it's like aorta stenosis. That's what. Continuous cardiac murmur flow through large collateral vessels. Okay, it's kind of like the PDA causes continuous murmur, so coordination of aorta causes continuous murmur too. Associated with intracranial aneurysm, Turner syndrome, aortic dissection and rupture, bicuspid aortic valve. Diagnosis: echo established diagnosis. MRA or CTA define the location of the obstruction and identify collateral vessels. Treatment: usually surgical repair, catheter intervention, balloon angioplasty, with or without stent placement. Okay, now another case, they tell you, okay, what drug, like they tell you, okay, 40-year-old came in with hypertension, whatever, you know, what drug increase risk for diabetes? Okay, so they tell you a bunch of hypertensive medicine you want to know. Okay, this is one, chlorothalidone. And then the reason they ask that, because they want to bring a discussion what medication, blood pressure medication side effects. Kind of important, yeah. So we have the ACE inhibitor, angiotensin 2 receptor blocker. This is minimal, no effect on blood glucose, reduced progression of nephropathy, first line treatment in heart failure, diabetes, and post-MI. So this is really good antihypertensive, lisinopril. Beta blockers increase risk for diabetes, except carvedilol, labetalol does not increase that. Others increase risk for diabetes. Will benefit patients with recent MI or stable heart failure. So this is helpful. Calcium channel blocker doesn't have effect on glucose, and useful with ACE inhibitor. Okay, the dihydropyridine calcium channel blocker. Okay, thiazide raise the blood glucose, LDL, and triglyceride. So it's a really bad drug for hypertension. Okay, it has a favorable effect on cardiovascular outcomes. Okay, because blood pressure and diuretics. Okay, so this is a summary of the first section of the cardiology. So we talked about chlorothalidone for hypertension, cause diabetes. Short stature with coarctation of aorta. Coarctation of aorta cause continuous murmur. PAD in ulcer picto. We talked about mitral stenosis, mid-diastolic murmur. Talked about 24-hour ambulatory blood pressure monitoring. Farm radionuclide imaging. We talked about proceed with surgery if no much risk factors like no stroke or kidney disease. And then we talked about when do you do aortic valve replacement, only if there is dimension more than 50 or EF less than 55 or symptoms. And that concludes summary of the first section of the cardiology, and we're going to continue to rock and roll for the next section.